And can you perhaps maybe expand on just some of these ethical considerations or perhaps moral dilemmas that you've encountered while treating rural populations?
Yeah, there's been quite a few moments. Well, one, obviously, in social work, there's a big element of dual relationships. And it's really challenging when you live in a rural community to not have dual relationships because, like I said, we care for the community we live in. And so it's like, that they may also be my neighbor, they may also be the person that I meet at the co-op or whatever it is. And so that sometimes can be a ethical thing you have to be aware of. But overall, some of the ethical and moral challenges have really come from, uh, just being able to get patients the care that they need and being able to be that advocate. It's been really challenging to work on the social work side because we used to be much more in that advocacy role. And I remember I was advocating for a patient whose surgery kept getting delayed and delayed, and it was an issue with an insurance thing. And I was trying to call the big hospital that they needed to go to. And they said, well, they would have to just come in and talk with our person. And I was like, they can't, they physically cannot do that. And then I got a response of, well, we don't talk to social workers. And I just was like aghast by that. And I'm one of those people that when you tell me no, like I'm like, okay, let me go. I'm gonna go, like the bear in the woods, like over, around, through, whatever I can to do what I can for the people that need it, because I take it very personally of like, they've they've put that trust in my hands, much like they put the trust in the oncologist's hands to pick out the treatment and to one that aligns with their goals. And so it's like when they put that trust in my hands, I take that very personally because I see, my mom, I see my little sister who very much needed those services, and how hard that was on a family system. And it's like when you add that plus the fact that they're, in pain and they're struggling, how could you not make this person feel like a person to, these bigger um, university systems and some of these larger hospital systems. So that's really what I've been trying to do from the advocacy role is be able to highlight that. And it comes with some challenges though too, because there's you kind of have to do it a little bit of a dance, you know. Um, you don't want to kind of call anyone out by any means, but at the same time, there's moments where, for example, um, had a patient that uh, needed to get to one of the larger facilities that is in our area, and I was trying to work with the other social worker who was wonderful, but they have a lot more legality around their accessing care. So, like, a patient has to be seen first as part of their policy, has to be able to get to their appointment first before they can help them. And the challenge with that is that then that puts it back onto us in the rural communities that are lacking in resources to be able to get a patient to that first appointment before they can access some of the bigger, fancier, grants or support. So that's been quite the challenge of from a professional standpoint of navigating that, but also not letting your frustration around those systems show too much sometimes.
Literally having them get their foot in the door. I also like the comparison that of you know a bear that you're gonna find a way, you know, find a solution, you know, over around and through kind of thing, because it just get kind of reminded me. It's like, okay, well, you kind of have to go mama bear at that point to then feel like you are protecting uh, them in that advocacy role.
Yeah, absolutely. I joke because I will literally say that. I'll say to a patient, listen, my mama bear instincts have been activated, and we will get through this, you know. And so it's yeah, it is kind of like a very protective mama bear role, um, but it doesn't always come with building relationships. But I try to as much as I can. But you know, sometimes it can be really challenging because at the end of the day, you know, it really does lead to significant delays in care, and that, as we all know, leads to poor outcomes. And it shouldn't be like that. So I will keep being a mama bear around those things as much as I need to.
Still having to do that dance. I was thinking like, oh, God, is it like a line dance where like there's these rules you have to stay aligned to, and like never been a line dancer, but you get my point where it's like you have to
Yeah.
follow along, right?
Right. Yeah. Well, and it's very eye opening when I have worked with some of the larger kind of urban facilities and things like that. Is just the disconnect between what it is really like out in these communities, you know. And sometimes we'll see that when we get like the discharge plans or something like that, and it's like that doesn't exist here. Like a when they might have like a medical shelter a lot of times. So for people who are with housing issues, there's like a medical shelter that you can discharge patients to in a lot of larger cities might have these things. Rural facilities, we do not have those things. And so that's been challenges that we've encountered too. I remember one time we had a patient who had just finished, he had a head and neck cancer and had just completed a, I can't think of, I'm going to botch the terminology of it, but when they resect part of the
The
throat,
thyroid.
the throat, no, his
Oh,
throat, his actual throat. Um, and was discharged with a J tube and feeding, and then the DME company was refusing to send him his his DME because he lived in a tent. And they said he doesn't have a refrigerator, and I was like, yes, I know that, and he will starve, you know. So it's just kind of, that's the kind of dance almost that you have to do sometimes, of like reminding people that there are people very much who live outside of the systems and the policies and all of these things, um, and reminding them that they're people, and there's, we have to figure out a way to meet their needs too.
Can you speak to fragmented care and your efforts to create a task force for the urban and rural populations?
Yeah, so fragmented care is, just to kind of break it down in a rough way of what it actually is it's kind of when people may dip their toes into multiple kind of care systems throughout their cancer journey, or even just healthcare in general. So you see this really a lot in the rural communities because, for instance, like one of the hospitals I work with, they're just now getting a radiation center, but for a long time they didn't have that. So patients would have to go to another healthcare system in order to access radiation care. But what you'll usually see with cancer is that, you know, you're not just seeing, you might be seeing a cardiologist, you might be seeing a pulmonologist, you might be seeing all of these other specialists on top of your oncologist, on top of your primary care. And it's just being, you'll see like all of the baton getting passed to all these multiple different places. And what ends up happening in fragmented care is that the baton doesn't get passed off as neatly as it does in a system, in a much larger system where everything's kind of in house. In communities, in the rural communities, it might be, oh, we've got to pass it off over to this hospital, and then they have to get imaging at that system, and then they have to come back to us, but then they need, and it becomes very complicated very quickly, and it also takes up a lot of uh, time. And like I said earlier, in cancer care, time is the biggest thing, the biggest factor that you want to eliminate as much as possible. And it leads to all these barriers for patients and also for the system itself. So it might be an oncologist will be trying to have, they'll want to do their initial consult, but they don't have the PET scan because they can't get in over here and they got to go to this place. And it just snowballs into this huge issue. And so I had maybe what might be considered like some bright ideas, but maybe a little idealistic or too big at that time. But I had a lot of hope for it, and I still do, um, which was essentially to build a relationship with a much larger facility and that we oftentimes do patient care with, like we'll refer to them pretty frequently. And so being able to create a connection there where we could have sort of, hey, we have these patients, this person's coming to you, so there's more of like a care coordination connection, so we're not doing multiples of the same thing, and the baton's getting passed back and forth much more fluidly. Uh, and honestly, it's been really challenging. It's been super challenging because of the just lack of understanding of what it's like being out in the rural facilities, and really how limited the resources are. But I think we're making slower headway. I think the biggest thing that is really missing is having that physician champion. And that again is another challenge, is recruiting physicians out to these rural communities and having somebody who really who understands the benefit of, and has the time, to be quite honest, to dedicate to building something like this. Um, but I think what we're seeing is that what's been effective is using what we call chronic care management tactics. Um, which is a lot of the work that I do from the telehealth standpoint, which is just calling the patient, checking in, referring to the chart, just staying kind of on top of, okay, you got this coming up, okay, you got that coming up. How did that go? Oh, did you need help getting transportation to that appointment? And just really kind of building an internal network as well, especially for certain service lines, like for us out in Port Townsend, the um, gynecological cancers. Those always need to be have a lot of baton passing, and so being able to have some doctors that we have relationships with and are developing more relationships with, being able to call up, oh, the nurse over there, and being able to advocate for patients more in a direct way. It's been really eye opening just how big those systems are, how small our systems are, and how disconnected that is. So, just still trying to figure out the best way while also maintaining quality care.
As I was listening to you talk about fragmented care, I like the analogy you used of really just waiting for a baton, because it does bring up a nice like visualization of like that, like a relay race where like it is time bound, like you can't do anything until you're handed that baton, and then you're able to then race forward and do that treatment. And I almost wondered if like that's like the treatment equivalent of playing the child's game of telephone. Like you're not necessarily getting every piece of information that's needed, and it just can get then um, over time convoluted or even changed in course, um, from when the initial message is.
Yeah, absolutely. That's really the biggest issue that we've seen is that you're relying then on the patient to be the person who's reporting and kind of managing their own care, but at the end of the day they're going through it. And I just feel like on a professional level we need to figure out some better ways of dialoguing and building relationships with these communities, um, and with these bigger health systems, and because ultimately we all benefit when the patient benefits. And I think like that's something that I'm a message that I really try to drive home is that fragmented care costs all of us. It means repeated tests, it means patients are waiting longer, which leads to more complex care. All of those things become expansively more expensive, essentially, when you think about, from a numbers perspective, which oftentimes hospitals do, and these when they're developing policies and things like that. And so being able to say, like, well, if it took this person 6 weeks to get in for this appointment, how is that effective for anybody? Because it's not only going to cost you more, it it's also costing, you know other the facilities more as well. And like sometimes we have to speak that numbers game, but ultimately it's really about recognizing is what it costs to the patient. It there have been times where like a patient's traveled out to a facility that was 2.5 hour drive to get to Seattle, and they will be like, "Oh, well, you weren't scheduled for today," or "Oh, we canceled that appointment." And they're like, and these are people who they chose to get to their appointment over, putting heat in their house for that month. And I think people just don't realize that those are the decisions that people are making out in these rural facilities just to get access to the specialists.
I was thinking about streamlined care and how this is kind of the opposite of that, with these complications and just barriers like you were describing, including that fragmented care. And something that came to mind is like, okay, well, like towards the the end of the life cycle for like salmon, like it's they're going back upstream and they're trying to like jump into these different areas and they're just getting like stopped. And so I just wanted to share that nice little visualization of rural care. Made me think of like, okay, these are salmon swimming upstream.
Right, exactly. That is exactly what it's like. You're going against the current, and the energy that a person or a social worker or the resources that are expended to go upstream, they do it because the reward is worth it. And that's the same for patients. They're expending all this energy to travel or to get what they need because it's worth it. But I also feel like we could make it so the current isn't so strong, so the barriers aren't so actively pushing back against them.